Good evening, everybody. My name is Keir Johnson, and I will be moderating this evening's session. Thank you for joining us for an important webinar from Doctors Manitoba on the COVID-19 vaccine. Just before we begin this evening, a moment on how to remind you on how to engage this evening. On Zoom, you can use the Q&A function, and depending on your device, this may be at the bottom or the top of the screen. You can submit questions at any time during the presentations tonight, and we have time for a question and answer period at the end of the webinar. We won't be using the chat function, and unless you're having some technical issues, of course, you can get in touch. And we also won't be using the hand up function. So the best way to ask a question is through that Q&A box. I'd now like to introduce the president of Doctors Manitoba, Dr. Corey Bailey.
Thanks, Keir. Welcome, friends and colleagues, to the latest of the Doctors Manitoba COVID webinar series. We have a excellent panel this evening to help answer some of your questions about the vaccine rollout here in Manitoba. We have Dr. Josh Reimer joining us again, who's the medical lead on the Provincial Vaccine Implementation Task Force, and she's also a medical officer of health in Winnipeg. Mr. Joe Funk, who's a deputy team lead for the Provincial Distributed Channel Workstream, who's worked on plans for clinics and pharmacies to offer the vaccine. Dr. Ainslie Mihalchuk will speak on behalf of the College of Physicians and Surgeons of Manitoba. She's the Assistant Registrar. Dr. Ian Alexander, who's the president of the Manitoba College of Family Physicians, will speak on the vaccine rollout and their perspective. Braden Kalichuk, who's on staff at Doctors Manitoba as a compensation analyst and is our lead on the vaccine response at Doctors Manitoba, and he'll speak on compensation issues for vaccinations for physicians. So our agenda this evening, we have a full agenda. Dr. Reimer and Mr. Funk will speak on the Manitoba immunization rollout and update us on Manitoba's plans. Mr. Kalichuk will speak on remuneration, Dr. Mihalchuk, and then Dr. Alexander. And following that, we'll have time for Q&A. We have some questions that have been submitted ahead of time, but we also welcome questions on the Q&A function on the Zoom app. So with that, I'll turn things over to Dr. Mihalchuk and Mr. Funk.
Thanks, Dr. Bailey. I'll start with this presentation and I'll hand over to Joe as we go through. But I just want to thank Doctors Manitoba for hosting this and giving us an opportunity to connect with my fellow members of Docs Manitoba about this monumental project that we're doing, and specifically focusing in on the work that we're anticipating seeing clinics do. So if you can go to the first slide. So what I want to talk today about is how we are prioritizing different populations. I'll give you a bit more about where we're at as far as how many doses we can provide and how, and then try to focus a bit on your role in the distributed model is what we're calling it. So in Manitoba, we are getting close to having administered 60,000 doses of vaccine. And as you may have heard us talk about before, we are trying to focus on getting that second dose on time to try to provide the best possible protection for our highest risk groups. We're obviously keeping a watch on the literature, and as information develops, it's always possible that we may move towards a different timeline if the evidence becomes clear that the delayed second dose is more beneficial. But right now, with the lack of evidence towards delaying a second dose, we've really been focusing on getting both of those doses in for everyone who's eligible thus far. We started with healthcare workers, which was partially because healthcare workers are obviously one of our highest priority groups, but it also came down to some logistics around Pfizer. Pfizer was the first vaccine to be approved, and what they told us when we first received it was that we couldn't transport it at all. It had to be administered at the site that we received it in the province. So that really limited us. We couldn't go to personal care homes, for example, at the very beginning. But we instead focused on healthcare workers, and in particular focused on the highest acuity healthcare workers such as intensive care workforce, to try to make sure that we were bolstering the healthcare system so that it was there to support Manitobans when they need it. But now that we've been able to have some more flexibility in movement of Pfizer, and we have Mrna approved as well, we're just finishing up the second dose at all of our personal care homes. So that's going to be very exciting when we finish that. And we're moving into other high priority congregate living facilities imminently. So that includes supportive living facilities, some of the long stay or ALC patients at hospitals, transitional beds, and then eventually moving into other congregate living settings that are medium risk. And that's things like corrections or shelters, and moving down the list with our teams through those. And you may have heard that we've announced that we plan to open up to the general population next week, which is probably one of the most exciting announcements that I've had the chance to make so far. I don't have an exact date yet, but everything's looking to be all lined up for us to open to Manitobans who are over 95 next week. So that will be very exciting, and we can move to the next slide to talk a little bit about how we actually want to deliver all of these vaccines. So our goal in Manitoba is to be able to give 20,000 vaccines every day. We're about halfway there in the building of our capacity. So we plan to do this through a variety of different settings. So you're already aware of our super sites. Many of you have probably already been immunized at our super sites, whether that's in Winnipeg or Brandon or Thompson. We've also announced that we're going to be opening super sites in Selkirk and in the Morden Winkler area. And we plan to open more of those as we go forward. We're also using pop-up clinics being temporary clinics. So they function similarly to the super site, but they're not going to be there for long periods of time. They're really intended to go serve a community's needs and then close down and move to a different community. Our focused immunization teams are the really small teams that have been going to the personal care homes and will be going to congregate living facilities. And these are really aimed to be a tailored approach. So we're going to be reaching a lot fewer Manitobans with our focused immunization teams, but it's those folks who can't come to us. So that's where these focus teams go, even though it's a small percentage of the population, it's a really critical percentage. And then, of course, what we're going to be talking about today is what we call our distributed channel. And that's more like how we do the flu campaign every year. So sending vaccines out to physicians and out to pharmacies so that they can be given in those settings rather than having to have the pharmacists or physicians coming to our settings to work there. So, this is our goal. We're going to be opening up more of all of these so that until we get to that 20,000 per day capacity. We are obviously not immunizing 10,000 Manitobans per day right now. This is what we could do with our current capacity if we had enough vaccine. So I want to go more to the distributed channel model and the reason that we want to do this, why it's so important. And as you all know, you are critical, trusted sources of information for your patients. We've seen it in many surveys. Docs Manitoba has pointed it out recently that physicians are the #1 place that Manitobans and that the population in general go for health advice. So that's who they want to be talking to vaccines about. And to be able to also provide them the vaccine in that same setting is not only very convenient, but also gives them that trust in that relationship to make that decision in that moment. Also, it's very convenient because there's so many. So rather than us trying to set up our pop-ups or our 10 or 15 super sites, there's 1,000 different locations across the province that we can use physician clinics and pharmacies. But all of this is dependent on us actually having a fridge stable vaccine, because I imagine none of your clinics have an ultra freezer that goes to -80. So that's where we're a little stuck right now, waiting to see if we can get something that's more similar to the flu vaccine ready to send out to all of you. You can go to the next slide. And the feasibility of that is really going to help shift and expand what we do And we're really just waiting on Health Canada at this point. They have told us to expect that Astrazeneca will be approved imminently. And I think we might need to redefine the word imminently at this point, because they've been telling us that for at least 3 weeks now. But we're going to be ready. And we already have a number of you signed up. So whenever imminently actually becomes now, this is the way we want to have this ready to go. But it's not just AstraZeneca. We're also trying to be ready for the Janssen & Johnson product, and the Novavax product, and whatever other ones come along the line in the future as well, so long as they are fridge stable and we can transport them. But once those get approved, then we'll start moving them through the channels that we are familiar with a few different changes around inventory and monitoring that make it a little different than our usual flu campaign. But if it is AstraZeneca, which we think it will be, then we've been told a little bit about what we can expect for the approvals from Health Canada. And what they're telling us most likely, and you can go to the next slide, is that they'll be approving it for people aged 18 to 65. That's a little challenging because we've been doing an age-based model. And we do know that elderly Manitobans are by far the highest risk of having those severe outcomes. So this means we're going to need to think a bit more creatively about how to best use this vaccine if we can't use it in the folks that we've said are our highest risk. And so we're talking right now to our medical advisory committee, which has a variety of specialists, including family medicine and immunology and cardiology. And, we've tried to cover a broad spectrum of experts there, but we're talking to them about what makes the most sense, which are the health conditions that are most concerning in the younger population. So the clinical trials so far show, broadly speaking, that the vaccine is maybe 65 to 70% effective in preventing symptomatic illness. AstraZeneca data is much more complicated than the mRNA trials because they did essentially 4 different trials in different countries that were run a little differently from each other. And so trying to compile all of that information into one summary has been challenging. For example, one of them used a 12-week window between doses rather than a 4-week, and their efficacy went up to 85%. So there's differences between the different arms of their trial that showed different levels of efficacy. And we're trying to work with that to come up with the best plan here. Right now, it looks like we would be doing that 12-week window in between the 2 doses because that's where we get our best efficacy, and that's obviously what we want. And if it does truly come out that it's less efficacious than the mRNA vaccines, then we'll need to think about providing an additional dose to people after they get AstraZeneca of another vaccine. It's very challenging. They haven't been compared head to head. So we'll have to be watching this and making some decisions as we go through things. But this is our plan right now because AstraZeneca can stay in the fridge for 6 months. It's much more feasible to send out to clinics. And so that's really where we're looking to go. And most likely we'll be providing guidance on which are the highest risk health conditions that should be targeted through this campaign. But we also need to think about other things like essential workers. Should they be fit into this part of things as well? And no final decisions have been made on that, but we are working on it. So I'm going to hand over to Joe Funk to go through a bit more of the details so that you can get a feel for what you can expect as this rolls out to you.
Thank you, Dr. Reimer. Can you guys hear me okay? Kier?
Yes, you're coming through loud and
Okay,
clear.
terrific.
Thanks.
Thank you. I'll apologize now. They're testing fire alarms where I am, and I've got my door closed, so hopefully doesn't create too much of a distraction. I'm not actually in Petersfield, Manitoba. I'm actually downtown Winnipeg. So anyways, yeah, thank you, Dr. Reimer. So in terms of rolling out this complicated program, it's very large, many moving parts. We're very grateful that we can rely on our physician and pharmacist partners to help us get this immunization program out to Manitobans. So one of the things that many have read about, we've got supply reductions and disruptions, and it has affected our overall campaign. It's very fluid. As Dr. Reimer indicated, we've been told literally for weeks that Astrazeneca, for example's approval is imminent, and we should get some sort of indication of when we might get an allocation at some point. So, and we have Pfizer turning off the tap for us for a while. So anyway, we've got a very big network we've built, and it's very hard to schedule things down to like individual trays of vaccines. So lots of challenges there, and we're going to have more. But everyone's been very good at working long hours and overcoming these. And we may face some with our channel partners as well. So because of that, we've had to scale up and scale down our immunizations. We've had to rebook appointments at some of our super sites. We've literally had to move product between sites so that people could get their second doses, so we weren't compromising people's immunizations, or at least we tried to mitigate the amount. We had an awesome plan, of course, and they turned the supply down so much that we even had to revisit second immunizations. But as Dr. Reimer said, all of our personal care homes are due to be completed, and that's an example of some of the success we've had. So in terms of recommendations on which eligible populations should be vaccinated, that's certainly not in my camp. We've got many people talking about that on a regular basis, and everybody's eager in watching those. That's something Dr. Reimer and others are intimately involved with every day. So I'll defer to her if questions come about in terms of how you do comorbidities and how you worry about different eligibilities, and which physicians should be looking at in terms of how do they go by eligible population. So essentially be following what everybody else is. If we could go to the next slide, please, Karen. Oh, that was fast. Thank you. So in terms of our projections, we've had to boil this down in quantitative terms so that we could do some planning. And what we've done essentially is, as Dr. Reimer said, we're looking at trying to at least get the 20,000 doses administered per day. We'd like to do that in the next month, say by April, by the beginning of Q2. And as part of those 20,000 doses, a number of them are going to be non-mRNA vaccines if we get them. And we're starting out with the hope that our physician and pharmacist channel partners can help us by administering at least 5,000 doses a day. So how we broke that down, I'll get to that. Essentially, we looked at all of the sites that we have in Manitoba participating in influenza vaccine campaigns in the last few years. And we said, if we could rely on 30% of the physician medical clinics participating in the COVID rollout to reach our 5,000 dose goal, we would need each of those facilities to provide 20 doses per day. So it seems like it's a fairly modest volume, but of course, every clinic has its own characteristics, its own client or patient base, geography, all kinds of things that go into it. But that's what we looked at. And if we can get 20 doses per day, and we presumed 500,000 doses as an example of influenza vaccine is a number we thought might be realistic given historic flu campaigns where I should say the physician channels have put about 500,000 doses through during a flu season. If we call it a quarter, and if we say 250 clinics are able to participate, we should get 20 doses a day. So that's where we based it. I can tell you as of yesterday, and the number's a little bit higher now, we have a combination of 150, I think it's now up to about 160 registered clinics who are COVID vaccine eligible when we get it. And if we use 20 doses per, we could actually administer 3,000 with your assistance, 3,000 doses in a day. So getting to 5,000 is not really unrealistic. We're at 61% of our goal already after a week of having registration open, which is tremendous. They're still coming in. I think there was a bit of a pent up backlog there and they're slowing down, but we could certainly shake the bushes again in the coming days or weeks if we need to. So if we could go to the next slide, that would be helpful. So with with the COVID-19 vaccine, as those of you who are already registered or interested in registering may know, it's quite unique because of the ultra low temperatures at which the mRNA vaccines have to be stored and handled. We've had to look at quite a bit of major details, not just the minor ones. And we've really changed a lot of what we do from regular flu campaigns to make it adaptable for a COVID campaign. So things like authorizing new providers, developing new fee structures. We've had to modify business processes and adjust logistics, and accounting for second doses. We've had to develop centralized reporting, which is something new. And this is all specific to COVID-19 vaccine. And as new products get approved, in fact, we may find, and as monographs come out and characteristics come out, we might find that some of these vaccines are 2-dose versus one dose. And the interval between second doses might vary between products, and other handling characteristics of products. How many vials they put in a tray. All these things we don't know, but when we find out, we're gonna have to quickly plan. And when it comes to the actual allocation of the products when they are approved, and Manitoba does get some, and we determine that some of those allocations should go through our physician and pharmacist channel, then we have to allocate. So we have to develop an algorithm that makes sense, that's appropriate for the epidemiology in the province, that's appropriate for the number and the type of clinics that we have around the province. There's a whole series of things. We're gonna have to consider how big the facilities, the clinics are, what kind of capacity they may have to actually administer vaccine, what kind of historic influenza volumes they may have done if they participated in vaccine campaigns in the past. So it's a very large algorithm with lots of factors, and we have to think about it methodically. We don't want it to be qualitative, we want it to be quantitative as much as possible so that we can apply some uniform, reasonable, and equitable to the degree possible algorithm that we can apply uniformly. Next, please. So the registration is underway. It's been open since the 8th. It's open 24/7. It's web-based. So far, it's been quite successful. Haven't heard complaints about the process. The medical clinics are registered quite quickly, usually within a business day or two. And we're having a webinar like this, and we're answering questions from Doctors Manitoba and from the colleges on an ongoing basis to try and get information out there and answer questions and make sure people are as ready as possible and as informed as possible. Whether they want to take part in the program or not is up to them, but we're here to share information. And so far, registrations and participation has been very good, so we appreciate that. So nothing more from me. I'll turn it over to Braden. Thank you.
Thank you very much, Joe. You literally took the words out of my mouth. Of course, the registration process does remain open. I'm sure the majority of our audience today practices at clinics that have registered and have been approved, but I suspect that some of our audience hasn't and doesn't belong to those clinics yet. So if you haven't registered and you intend to do so, or if you're perhaps unsure if this program is right for you, I'm certainly hoping that the information presented today can help you make your decision one way or another. The first point I would emphasize is that this campaign, in some ways, will look a lot like a flu shot campaign, but in many others, it certainly won't. You heard earlier the projection of volume per day of 20 injections for a clinic. We suspect that that's very reasonable in terms of the amount of time that's going to be required to provide these services. So from that perspective, things will look quite a bit different than what you might be used to in a flu shot campaign. Here are some initial requirements for clinics that are above what you would typically expect in a flu shot campaign. So first and foremost, physicians and their staff will be expected to verify a patient's eligibility and to obtain consent. The expectation will be for clinics to provide immunizations both to the patients on their roster and also those that aren't. This presents a barrier that we're trying to avoid for Manitobans to be able to access immunization to COVID-19. The expectation will be that physicians submit claims within 48 hours of service delivery. This is, of course, quite a significant increase on the administrative side for your staff. This goes towards public health having an understanding of what kind of service is being delivered and how effective clinics are being in getting the doses out into patients. So that's a significant increase. Clinics will be expected to report on a weekly basis on their stock levels, including usage and wastage. This is very important for the province, of course, to have an understanding of how much inventory is out there and when to restock your fridges. Similar to flu shot campaign, the expectation will be that clinics keep their patients around for a 15-minute period of time. And similar to flu shots, the expectation will be that if there should be any adverse reactions, that the clinics are reporting those. Skip forward here. So onto the remuneration side of things, Doctors Manitoba and Manitoba Health have negotiated a tariff for COVID-19 immunizations. This tariff comes in at $20 per injection. So as Joe alluded to, many of these products will be a two-dose process for each patient. That means this tariff will be billable twice for each patient. I don't know if I mentioned earlier, but the expectation will be that clinics take arrange for both appointments for any given patient that they're booking. So whether that's an on-roster or off-roster patient, the expectation will be that your clinics are making arrangements to provide both immunization services to those patients. Additional patient interactions may be billed as regional visits where medically relevant, and I stress where medically relevant. This is a bit of a misnomer when it comes to flu shot campaigns that visits are billable in addition all the time. That's certainly not the case. To provide a couple examples, if a patient were to schedule another service with you and receive their vaccine at that time, so for example, if a patient makes arrangements to have a routine physical done or an investigation into another complaint, and the immunization is provided at that time, of course, any tariffs that apply to those other services are billable in addition. If a patient exhibits anxiety or hesitancy towards the vaccine and requires a period of counseling prior to injection, that would be that would satisfy the medically relevant requirement. It could be billed in addition. And also, as I alluded to, the expectation will be that you are seeing patients that you've never seen before for this. And we don't take that lightly. We know that will mean you as physicians will be obligated to do a little bit of background on this patient before you're jabbing them with an immunization. So that work will certainly be billable in addition where medically relevant. I would stress, and I stress this just about every time I talk billing or tariffs with anybody, that documentation where a visit is claimed is absolutely vital. That this should go without saying, but in a campaign like this where tariffs may or may not be billable in certain circumstances, if you are billing for an additional service at the time of these services, I cannot stress enough the importance of documenting well and having that information ready on hand. So that's a lot of information really fast. If you are interested in having further discussions with myself or the Doctors Manitoba negotiation staff team, you can certainly direct your questions to our staff and we'll be happy to elaborate further.
Thanks, Braden. I'll now ask Dr. Mihalchuk to give the perspective of the CPSM.
Thank you so much. Appreciate the opportunity from Doctors Manitoba to contribute to this webinar this evening. From the college, we are certainly pleased to see that this very important vaccine rollout is occurring in such a collaborative of organizations across the province, particularly as they represent physicians. So it really is a sentiment of we're all in this together. And I think that is absolutely the sentiment that CPSM brings today to this conversation. We absolutely recognize, as has already been pointed out, the incredibly important role that you as physicians will play in the vaccination efforts, and how much of an opportunity this is to contribute to the most incredible vaccine effort that's really ever been put forth in Manitoba, and what an important role that you play in that. So thank you for all the work that you will be doing to help to vaccinate Manitobans. From the regulator's perspective, from a frequently asked questions we have posted on our website. They were all sent around already to the profession, but we would ask you to go to our website if you would like to review them. I'll give you a few highlights here tonight, but the information on our website also links to all of the important documents that you would need to look at from Public Health or Manitoba Health relative to how to appropriately administer this vaccine. So the college expects that you will follow Public Health and Manitoba Health vaccine requirements, including for the reporting that has just been described, and submitting claims so that the province can keep track of the vaccine doses that have been administered, but also any wastage and all of those other important aspects that have already been identified. The college also expects that you will follow eligibility criteria as outlined by Public Health, recognizing that this may change and evolve throughout the vaccine campaign. The college specifically points out that it's not ethically appropriate to use vaccine that's sent to your clinic environments to vaccinate family and friends outside of an order that would be appropriate according to eligibility. We also want to make sure that you educate your patients and advise them appropriately about whether they should take the vaccine or not, if there's a reason you feel that they shouldn't, and also to look at giving advice in alignment with current evidence and public health guidance. So to remember that you are a trusted source of information. Your patients are looking to you for what to do, and the college expects you to do the best that you can with the information that we have, recognizing that this is a constantly evolving situation. And so on behalf of the college, thank you to all of you for the excellent work you are doing and will do to provide vaccinations and support the efforts of care during this pandemic.
Thanks, Dr. Mihalchuk. And Dr. Alexander, could you speak to the support that the Manitoba College of Family Physicians is providing?
Thanks so much, Dr. Bailey, and thanks again to the staff at Doctors Manitoba for this important webinar that we're having here tonight. I'd like to echo Dr. Mihalchuk in the importance of the collaborative nature of this rollout, including Doctors Manitoba, the College of Physicians and Surgeons, Manitoba College of Family Physicians, as well as the Vaccine Implementation Task Force. We know that physicians of all types will be involved in the COVID immunization program, but family physicians will take an important role in the immunization of our patients. As such, we're developing a variety of resources that will be available not just to family physicians, but all physicians in Manitoba to assist with the rollout of the COVID-19 immunization program. We're working on a provincial toolkit full of different things to help you inform your patients, as well as ensure that your office is set up properly to assist with the COVID-19 program. This should be coming in the next 1 to 2 weeks, and we will be having a webinar available shortly after that to assist with the launch. This will be a toolkit that's updated over and over. So please make sure to check back and ensure that you're up to date with what information is available. Thank you.
Thanks, Dr. Alexander. So in the interest of time and ensuring we've got more time for what looks like a lot of questions coming in on the chat, I'm going to abbreviate the Doctors Manitoba update. With the exception, I just want to share this one slide illustrating a lot of the new vaccine resources that you can access through the Doctors Manitoba websites. You can see on the slide all of the tools that we have available there for you that you can access at one click on your computer or tablet. Especially would like to highlight the guide to vaccine hesitancy. I know this is an issue that all of us are seeing in our practices. Many of you may not have had the opportunity to attend the previous webinar on vaccine hesitancy, and Keir and the team at Doctors Manitoba have put together highlights from that evening's webinar that physicians can access and address these questions that many of our patients have for us about vaccines, so that we can optimize the rollout of the COVID vaccine when it's available. So with that, why don't we start with questions for the team. And I guess this question likely would go to Dr. Reimer or Mr. Funk. Question about what training specifically is offered to physician clinics that offer to vaccinate.
Yeah, maybe I'll start and I'll see if Joe wants to add any details. So when we're talking about the fridge stable vaccines, largely speaking, they're very similar to the vaccines that you're already used to using. So while there certainly there's going to be items like the toolkit that Dr. Alexander was talking about, the specific training needs are much less than for the mRNA vaccines, where the storage, where the way that it's prepared is all quite different than what we're used to. So right now, the main focus would be on getting access to resources for physicians who are going to be immunizing in their own clinics. But definitely, if the physicians are signing up to work in one of the mRNA clinics, then that's we would have training around the mRNA vaccine specifically, as well as training around entering data into the public health information management system. We are not requiring physicians to, in their own clinics, enter directly into that system, and we'll be using billing data as our primary source of data collection for that, along with some other enhanced components. But I'll maybe see if Joe wants to add any other details about training that may be provided for physicians.
Yeah, thanks, Dr. Reimer. There's no formal training. There's certainly no technical training requirement from our perspective. So for those of you that have provided flu vaccines or other vaccines in the past, you'll be familiar with most of the processes. I think the only thing that would be perhaps materially new for medical clinics would be the fact that now you're tracking inventory a slightly different way, with more regularly, perhaps with a little bit more detail, going through a web tool that we've prepared and tested. So essentially, the missing piece that you don't currently have will be a process in your own clinic to make sure that you can track the inventory, and then the tool itself that you use, which I think is a 3 or 4 screen drop down tool that's web enabled, where you'll put your vaccine inventory and waste statistics in there on a regular basis. And it's pretty intuitive from what I've seen, and it's not very involved technically. So we don't envision a formal training program to use that tool, but there certainly will be support on our team for people who have issues with it. But I think it's going to be pretty straightforward in terms of using that web enabled tool. That's about all I could see as being new. And Dr. Reimer, I guess, as someone who operates a clinic, that you'll have an interest in that as well, right?
Yeah, and I think that the toolkit and some of the fact sheets that we've developed will be very useful to help inform how to have the conversations with patients. And you know, we're so thankful to the Manitoba College of Family Physicians for taking on some of that work to assist to develop really relevant tools for physicians.
Great. Thank you so much, Mr. Funk and Dr. Reimer. I'm going to try and do a twofer here with a few questions that have come in and some that were submitted in advance. Obviously, a lot of physicians are keen to help with the rollout and keen to support it, particularly worried about their elderly patients, and hearing that the vaccine they'll be able to offer in their clinic is not for the elderly patients is a little distressing to some physicians. So I guess the question is, first of all, some have seen other jurisdictions offering the Pfizer product in GP practices. And so I noticed in the chat, Dr. Reimer, you said that's not in the cards right now. But is that something for some practices, with the refrigeration period of 5 days that could be considered? And then I guess the second part of it is, what do you recommend doctors say to patients when they feel like they're getting, the Pinto instead of the Lincoln when it comes to vaccines? Is 66% now better than waiting who knows how long for 95% effective later? Like how would you frame those conversations? So again, part one is any hope for them to be able to offer a vaccine to their elderly patients, and part two is how to have that conversation.
Yeah, I'll try to answer both parts of that. So in regards to having mRNA vaccines in physician clinics, I mean, nothing is off the table. We're trying to start with the most efficient process possible to reach the largest number of people possible, but we do intend to continually evolve and improve and seek out better ways to reach more Manitobans. So yeah, the Pfizer can be kept in the fridge for 5 days, but that would need to include transportation time as well, because we can't transport it frozen unless we send you 1,100 doses at a time, which I don't think most clinics would want 1,100 doses at a time, maybe some would. So it's not off the table, but we just need to start with the most efficient mechanisms possible, and then we can build and fine tune from there. Regarding AstraZeneca, I would say Manitoba is not excited about the way that NACI is framing AstraZeneca compared to the mRNA vaccines. So they're quoting things like the 65% efficacy. We're planning to use it with dose 2 happening 12 weeks later. So that's more like an 85% efficacy, making it really comparable to the mRNA vaccines. We also know that when it comes to medications, we would, unless there's been a head-to-head, we would really never start calling a medication inferior or superior or more or less effective on its own without more data, trying to do a head-to-head, or at the very least multiple trials that look at it in different settings. The AstraZeneca trials were done with different patient populations, different variants in different countries. They included younger populations compared to the mRNA. And so it's really hard to actually truly say that AstraZeneca is not as good. We might see that as we go forward because we're putting millions of doses out and doing these real-time trials with the population. But the UK is treating them as equivalent right now. We were surprised that Health Canada told us they were not planning to approve it in the elderly, because while there were not very many elderly in the studies, there's also not really any reason to expect it would be harmful to the elderly. And certainly getting more doses to the highest risk people seems wise. But we are where we are, and we have to abide by Health Canada approvals. So the message to patients is, it's possible that this one might not be as effective as the other vaccines. We don't confidently know that yet. If we discover that it is less effective, then we're going to make sure that all Manitobans do get offered the most effective vaccine that we have available when we can. So we're not going to leave anybody hanging who decided to go for AstraZeneca if we later come back and look and see, no, truly it actually is only 60%. So that needs to be the message to folks. And I guess one of the bonuses of it not being approved in the elderly is that the message can be, you're not up very soon, so you can get this one now and you can get very good protection. 70% or 85%, because that's what the approach we're going to be using. 85% is a very effective vaccine. We would be very satisfied with that with many vaccines. So to be able to, bump yourself up in the queue by many months to be protected 85% is still hugely beneficial, knowing that we're not going to let anybody end up with a worse vaccine if that's what we discover. And so they would be able to potentially get a different vaccine later on if that's needed.
Thanks, Dr. Reimer. Questions in the chat. Again, you brought up decision-making framing by NACI. Anything, I'll do a 2-for-1 as well. Anything new to report in terms of the pregnant population or immunosuppressed population? And then on that front, there were concerns in the chat about the challenges of the consent and especially the enhanced consent process. Do you anticipate any changes in the near future to the enhanced consent process here in Manitoba?
Yeah, so on the first go around, NACI really said, don't immunize folks who are immunocompromised or have autoimmune conditions or are pregnant or breastfeeding unless, and then had sort of a list of things that you could consider. They've now reframed it as, you can immunize these people if you just have a conversation with them about what we know and we don't know. So they've softened their approach quite a bit to those. And likewise, Manitoba, we removed it from the call center, so they are not screening people out based on any of those conditions anymore. And it's not finished yet, but it's very close to being done with just a single consent. And it's going to have a little section for people who may have additional considerations, but it'll be the same consent form for everybody with a plus or minus of filling out that second section, just a small portion of the consent. To try to minimize the confusion and the effort. And really, there's no data showing that it's harmful for any of those populations. There's a theoretical risk that it could trigger or exacerbate an autoimmune condition. There's a theoretical consideration that somebody who's immunocompromised might not have as strong of a reaction, so it'd be less effective. And then there's always a theoretical consideration with pregnancy and breastfeeding because we never do trials including those patients. And it's not a live vaccine, so even less of a theoretical consideration than some other ones. So, clinically, I wouldn't say that we're very concerned about offering to those populations, but we do want to try to follow NACI, and that's the guidelines that they've set up.
Thanks for that, Dr. Reimer. Some questions here about eligibility for physicians and staff in their clinics. And this might be a bit of a 2-part answer in terms of eligibility. So maybe just clarifying who's eligible right now for community-based physicians and healthcare workers. And then for those clinics that have registered to be an immunizing site, at what point does their eligibility change because they're a designated immunization clinic?
Yeah, that's a great question. And I think we're going to try to send out something more formal to everybody. And it just hasn't made it quite to the top of our list of many, many things that we want to send to all of you. But something formally saying, this is when we anticipate eligibility and this is how we plan to do it. So right now for all physician clinics, anybody who's born before the end of 1955 is eligible to book through our call center, go to the super sites and get a vaccine. So that's anybody who does direct patient care in a physician clinic. It doesn't have to be a physician, but it has to be a physician clinic or nurse practitioner clinic. So that already exists. Sorry about the sirens. And once we have the approved vaccine, and clinics truly do become immunization sites, that's when eligibility will be broadened So you're not eligible yet unless you meet the age criteria, but that the intent is to offer vaccine to any, really probably all of the staff in any clinic that's providing immunization. We're talking a lot about with the Astrazeneca, taking the additional few doses at the end of a vial so that you can offer to any of your staff in your clinic at the end of each day to reduce wastage and also to reduce the inevitable temptation to waste a dose but then give it to a staff member, because it's very hard to see your staff and not be able to give them a dose. And so we just didn't want to encourage people to feel like lying to us was beneficial. So very probably we're going to say something like, at the end of each day, when you have 1 or 2 doses left, then please use those for any of your staff in your clinics, treating them as a patient and going through the whole process as per usual college rules. So yeah, that's the plan going forward. I think the age criteria is going to continue to decrease, meaning younger and younger folks are going to be eligible in your clinics while we're waiting for AstraZeneca. So keep checking the website because we plan to keep expanding that until such time as we have a shift in our process.
Thanks. Why don't we give you a rest, and I'll send a question I think is more up Mr. Funk's lane. So question about if the elderly, so above age 65, aren't going to be immunized in physician offices and are going to have to go for the super centers, are there changes being done logistically to make the super centers more elderly friendly in terms of distance they have to travel, walking, being able to take a caregiver with them? I've not been to the super site, so I can't speak to the logistics of that, but there were concerns raised in the chat about that for our elderly patients. Mr. Funk, could you address that question?
Thanks, Dr. Bailey. What I might suggest, I can certainly take that question back. It's a different work stream, and I'm not that familiar with modifications being made to accommodate patients like that at the clinics. I'm not that familiar with the issue, so it wouldn't be fair for me to make something up. But I can certainly get back to the group with an answer, and perhaps through care it can be distributed that way. I've heard about the issue, but I'm not too sure I fully understand it or what might be underway to accommodate it.
And I don't have much of a longer answer, but I do know that they are working very hard on that right now, which is part of why we announced early that we were going to be opening up to elderly Manitobans, is to start working on how do we change our processes to be more friendly to people who need more time, who need more comfortable space, who need to have someone accompany them. So I don't know the exact details of what the team is doing, but I do know that they are working on it right now. And things like having someone to assist them would absolutely be one of the things that will be included.
How would it be best to get the response back,
Thanks.
Dr. Bailey?
Yeah, I think if you answered to Keir, he would certainly be able to get the information out either through our COVID newsletter or on the Doctors Manitoba website. So thank you for that.
Okay, yeah. If there's more to add to what Dr. Reimer said as things evolve, we'll get back to Keir with that answer. Thank you.
Thanks so much. We appreciate the follow-up, and questions that we don't get to tonight, we will also try and follow up on all of those to make sure we can get answers for people. Just a question, and I think you may have touched on this a little bit already, but we'll dig a little deeper. If there's clinics who want to do more than 20 shots a day, or they'd like to do 100 shots over the week in one day, or they're a very large clinic with dozens of physicians versus a small clinic with 4 or 5, or they're in a rural community where there's no other clinics. Are these kinds of factors taken into account? And you described it a little bit, Mr. Funk, when you were talking about the distributed channel model, but I think physicians are keen to help. There's lots who'd love to 100 or 200 a day if there was enough supply. And is there the ability to go beyond the 5,000 a day that you're looking at?
I would say if there's sufficient vaccine allocated to Manitoba that we can put through these channels, the sky's the limit for how much we would ask these channels to administer. In fact, if we're sucking away from super sites because people want to go through their own caregiver, I think that would be awesome. I think the limiting factor right now is that we may have to ration vaccine if it's rationed to us. And of course, then some allocation rationing is going to limit how much clinics can do. But we wouldn't limit a clinic if it could literally put through 300, 500 doses in a day. If they want to do special 12-hour-long clinics 3 days in a row, and there's enough vaccine, we would say by all means, if that's what your patient base demands, and we can get the vaccine there, just tell us how. Well, don't tell us how, just tell us when you're ready for it. And if we have enough, we'll get it there. Does that help?
Yeah, I think that helps. And maybe just as a follow-up, I think what I'm hearing is if there are clinics that want to go beyond, an average of 20 shots a day, is that something they could email the application email address to signal that to provincial officials, or how would they let you know that they'd like to do more than the average?
Yeah, that's a good question. I mean, I'm not too sure at what point we're going to tip over from having scarcity of supply to overabundance of supply. I think what I anticipate happening is there's going to come a time, fingers crossed, that happens, that we have some indication from manufacturers that their combined supply to our province is going to put us in that position. And I would like to think at that point we would be proactive and we would go out to the registered clinics and say, we anticipate an overabundance. Can you give us an indication of your capacity and your desire to do more than we're currently allocating? So I would say we would probably, with that kind of warning, come out and solicit it at that point. That's all I can say at this point, just because I don't anticipate there being an overabundance for a number of months, and hopefully I'm wrong, and I'm wrong early.
So just before I ask a follow-up question of Mr. Funk, I'll just let people know it is 7:30, but the panelists all agreed ahead of time to stick around for a few more minutes if we had lots of questions, and we do. So why don't we plan for another 10 or 15 minutes of questions? So just for those of you who are on a schedule this evening, you can plan for us to be done around then. So question from a rural physician in the Q&A about is Manitoba Health looking at or somehow addressing equitable distribution of vaccine in different areas across the province, and such that if a number of clinics in one rural area all had applied to offer to vaccinate, will just one site be selected? How is that process being done to ensure that there's equitable distribution?
Perhaps I'll start with that, Dr. Bailey. Yeah, it's an important question, and it's something that we're spending quite a bit of time on here. There has to be a number of ways when we're in rationing mode to allocate it equitably. And we have to look at how the distribution of participating clinics and pharmacies align with the epidemiological heat maps in the province and the populations in the province. There are a whole number of characteristics of clinics and populations, and they're going to evolve. And there are also going to be characteristics of the products that come out. And we'll also have to work that into the mix. So suffice it to say that we're developing an algorithm. There will be a model. It will include certainly an allocation among the regional health authorities. It'll have to evolve because we may find that registrants are all congregated in certain parts of fewer health authorities than others. And so there would be perhaps I wouldn't say an oversupply, but an abundance of vaccination capacity in some parts, and maybe we're going to need it more in other parts of the province in different RHAs. We also have to take into consideration the fact that we have large super centers in some of these RHAs, and we're going to have to adjust how much allocation goes to an RHA if they've got super sites. So there's a number of factors that we're going to have to consider. It may not be 100% equitable because there are too many factors to to consider concurrently. We want to make sure that there's allocation to pharmacies as well as medical clinics. We want to make sure that regional health authorities are getting looked after also with some equity. We want to make sure that clinics who've been good partners in flu vaccine programs in the past get some consideration. We want to make sure that clinics that have capacity to do large volumes in areas where it's needed get consideration versus those that maybe haven't participated much in the past or can't do large volumes or don't want to do large volumes. So it's very complicated, and then we're not going to have a perfect way to allocate. We're going to try to make it as objective and as qualitative as we can, and we may even come back to the group for some perspectives on our allocation when we come up with a model for it. And the model is going to evolve. As I said earlier, as we find out what products we may actually get allocated to Manitoba, we may find that some have got a broader interval between doses. We may find that some are one dose. We might find, I'm presuming they're all going to be fridge safe 2 to 8 degrees Celsius, so maybe that's not a consideration. But then we're going to have to start asking participants, do you want 4 products in your fridge? Or are you going to be more efficient and effective with just one of the products in your fridge? So then we also have to consider, I want 3 products. I want all 5 products. I just want the one. So there's going to be many, many factors that go into it. It'll be very complex, but we're certainly thinking about it and working on a way to start so that it can be equitable and fair and serve the eligible populations and the epidemiology as that evolves, because that too will evolve as we start to saturate areas with vaccine, and maybe some parts of the population are very eager and they all get populated. Well, maybe that region now has very, very little number of people that still need vaccination, and others are higher. And maybe there's a breakout in an area. So it's complicated. My short answer is we're thinking about all those factors, but it may not be a perfect solution for everybody. Thank you.
Thank you very much. Just a question, and I know this is probably a difficult one to answer because it depends, but just on timelines, when you think stage 2 and stage 3 will really start, and ultimately a question around when you think that we'll be in a position to say that everybody who wanted to be vaccinated could be vaccinated. So I think we'd accept maybe a range if you've got kind of a realistic best case scenario, not maybe not what we've heard on the news of, that you could vaccinate everybody if there was enough supply, within a couple of months, but maybe a little more realistic in terms of what we know about the supply that's coming and what those kind of realistic ranges might be.
Yeah, that's a tough one because it depends on what else gets approved. So if we're assuming that we're only using the currently approved vaccines, then we're looking at using all of 2021 to reach all of Manitoba. If we are getting, and we used an estimate of 700,000 doses of non-mRNA vaccines, we think we can reach all Manitobans by the end of August. So it's a pretty big difference. And maybe it's somewhere in between those. Maybe it's faster than that. Maybe we'll get 1 million doses. So we are doing our best guesses. We're opening up to elderly Manitobans next week. So that's part of stage 2. We also have started doing part of our stage 2 when it comes to healthcare workers by opening up to outpatient settings. So we really are starting stage 2 right now. And we'll be slowly going through that. And then I anticipate we're looking at a few months down the line before we hit stage 3. So, late spring, early summer would be my best guess, but it's just so much variability that it's really hard to know.
If I could just add to that, don't let it be said that we are not getting ready with our partners here to be at the ready when vaccine arrives. So if we actually get some vaccine allocated to Manitoba that's appropriate for these channels, it can't be said that we're not ready. We've already got hundreds of registrants applying and eligible, and so we'll be good to go. So when we find out we're getting some, you'll find out that we're going to distribute, and then it's a matter of allocating, and we'll be good to go. So there's no delay on our side. It's delay on the manufacturers and I guess to some degree Health Canada side.
Thanks. Questions from some physicians in the community about what changes once you're immunized. Does that change for physicians the precautions you need to take in your clinic? Does it change requirements for isolation if you've been immunized and potentially been exposed? What would be the answer to that, Dr. Reimer?
Yeah, I mean, that's a better Dr. Rusin question than it is a question for me. As far as I know, not a lot changes yet. We don't have good data on whether or not the vaccines prevent transmission. We have data that they prevent illness. So it's hard to make a lot of changes, but I do know that the public health team is looking at things like, redefining close contacts. So that, if you're asymptomatic, that you might not have to self-isolate after being a close contact. I don't think that they've actually posted that or moved in that direction, but I do know that that's being discussed actively. We're discussing things like, could we change the definition of an outbreak at a personal care home so that you have to have 2 people with an infection rather than shutting the place down when there's 1 person who swabs positive. So there's certainly a lot of things that are being discussed, and we don't have any changes that are happening just yet, but I expect it'll be pretty soon when you start to see some of those changes coming out.
Thanks. A couple of questions just about safety. There's initially some stories about anaphylaxis that caught a lot of public and media attention. But what's the latest on anaphylaxis, and if that emerging data is positive, would we see a change in the 15-minute observation requirement?
Yeah, so there was maybe I'd say like a flag, so not a clear increase, but a flag that maybe there was an increased risk of anaphylaxis with the mRNA vaccines compared to other types of vaccines. I know in the States, they've actually downgraded their risk. So they were reporting something like 10 per million, and they're going down to 5 per million. Don't quote me on those numbers. I'm trying to remember what Tim Hilderman told me because he reviewed their recent changes. But I know that they cut their estimates in half very recently. In Manitoba, at first we had a flag that we were a bit concerned about, that it seemed like we were getting more anaphylaxis than usual. So we actually had a committee review every single case that got reported as an allergic reaction. And I would say none of them were anaphylaxis. There were a couple where technically they checked the right boxes to meet definitions. But if you really sat down and talked through it, the clinical situation didn't make any sense. So for example, we had somebody who 22 hours later had a rash that we don't know if it was pruritic or not, but had a rash and then had some shortness of breath. But wasn't able to really explain, because it was a very elderly patient, so wasn't able to explain the symptoms. So you now have a skin and a respiratory symptom happening within 24 hours, but didn't respond to epinephrine, didn't respond to antihistamines. So checks the boxes, but pretty unlikely that's anaphylaxis. So I would say it's still something that we're watching. We're still certainly concerned that there's a possibility of higher risks of anaphylaxis than other vaccines, but we're slowly getting less concerned, I think, than we were right at the beginning, but don't intend to decrease our vigilance on watching for it anytime soon.
Question about, do you have information about the efficacy of the AZ vaccine against the new COVID variants? What data are available about that?
Yeah, there was a small study that came out of South Africa that did show that it seemed to have decreased efficacy against the variant that was first identified there. Now they've stopped using Astrazeneca, so I don't anticipate we're going to get better research on that one in the near future. So far, it seems like the 117 that we saw come out of the UK That one seems to have pretty good coverage from most of the vaccines. Just today, I saw a report that possibly the mRNA vaccines might be less efficacious against some of the variants, but I haven't even had a chance to read the actual study yet because it was today. There are thousands of different variants. Manitoba has a few of our own variants, and we do anticipate that there's going to be variability in the effectiveness of different vaccines against different variants. That's one of the good things about having multiple products being available, is that we are hopeful that if we can provide a variety of products to Manitobans, that it will help to decrease the ability of the virus to circulate, even if there was a specific variant that entered the province, once we have most people vaccinated, that is.
Thank you so much. I'll ask a question about the physician's role in the consent process for those patients who are going to super sites or getting the vaccine elsewhere, maybe even at a pharmacy. So a couple of the examples that have come up would be elderly patients who might want to seek information or help with the consent process from a familiar face, from a physician that knows them. And if the province could actually even reinforce the option to talk to your doctor for questions, or if you have consent questions as well. So is that something that you could see the province moving on? And certainly, would you see physicians reaching out to their elderly patients as they become eligible to see if they have questions and encourage them to get the shot if appropriate?
Yeah, so I actually really love the idea of having physicians reaching out to their elderly patients or their patients who they know have significant health concerns, where a more in-depth conversation would be beneficial. I think it's a great idea to have physicians reaching out and working through some of those more complex situations, or even if it's not more complex, the folks that need more time, need a familiar face, need the opportunity to work through things more slowly. We would be very happy to have physicians connecting with their patients on this. I would assume that if you fill out the consent form that our super centers would accept that, but I would have to ask to make sure that that's true. I mean, I guess worst case scenario is they would have to sign it again in the clinic, but hopefully feeling comfortable that they've already gone through all of the information process that led them to sign the consent in the first place. So that little tiny logistics piece I'll have to take away and come back, but the actual functional side of it, it would be very beneficial to have people feeling comfortable that they've had somebody walk through their personal situation with them to come to an informed decision.
Thanks, Dr. Reimer. So we're at 7:45, so I think we'll draw this evening's webinar to a close. I'd like to sincerely thank all of our panelists for offering their time. I'm sure this isn't their first Zoom call of the day, and it's really appreciated the offer the time to help out the physicians so that they can be better able to care for their patients. I'd like to thank the members who took their time out to be educated on this important topic. We had close to 200 physicians on the webinar this evening, so obviously something that you all care about, and thank you for taking the time. Please complete the short feedback survey after the webinar so that we can optimize our service to you going forward. Just a few questions that'll help us do a better job as we continue the webinar series going forward. So with that, thank you and good night.